Okay, I think in interest of time, we are going to start. Um, and this talk is on thoracolumbar fixation techniques and SWFNS Spine Committee consensus on thoracolumbar fractures. So we looked at PubMed and looked at Google Scholar, and this is from last 10 years database. And we put in these keywords, and we got 1, 2, 2, 3 hits, and 1, 6, 7, 8 hits respectively. Most of the hits were duplicate in these. And then we deleted the ones that were not English, and we included only the human studies. They include case reports, case series, prospective, retrospective, randomized studies, systemic reviews, and meta-analysis. So of those, we went through 30 articles, which to have an idea what exactly we're looking at. So etiology, thoracolumbar fractures, one of the most common health problems. Unstable, according to principles of AO classification, fail to respond to conservative treatment, need surgical intervention. High energy trauma by falls and sports related, we already know this. 20% of fractures are burst fractures. Osteoporotic fractures are considered as type A compression fractures. Surgical indications, generally burst fractures, which are severe neurological deficits, neurological intact patients with no loss of disruption of PLL, interference of inference from the greater than 25 degrees of kyphosis, and distraction injuries, seat belt injuries, and chance fractures require surgical stabilization because of loss of integrity of the posterior column. Translation injuries, rotational injuries, as we have already discussed, so not going to go into that, not going to go into this. This all has been done. General indication for AO as per AO classification by guidelines made by our friends in AO. They felt that A1, A2 fractures when compression is more than 50%, depending on the state of the posterior ligamentous complex, we can decide are we going to operate or not. Again, A3, A4 fractures, depending on fracture configuration, and B and C fractures are unstable, hence operative management is mainstay, as just discussed by our previous speakers. Techniques for addressing, there is no gold standard. This is improvement, so there are many studies, but every study at the end of this says that, whatever is best in your hands, use that, but there is no gold standard technique. Choice of surgical technique varies among spinal centers and according to spinal surgeons' preference, as Mehmet just told us. Techniques could be all of these or any of these, and there are various techniques, and all of them, we'll just go through them one by one. So posterior spinal instrumentation, most frequent method of fixation due to low morbidity. And majority of us are now via just the posterior approach. So overall posterior fixation, but if you have a reasonable anterior element intact, then you can do exactly the same job that you do from anterior posterior just by posterior approach. When there is no anterior support, the injured disc and the fracture vertebra may collapse further and result in loss of reduction by 7 to 9%. But 7 to 9 degrees, but you lose that anyway, no matter you go anteriorly or posteriorly. This person investigated the relationship of post-traumatic kyphosis with type of fracture and location. They found that A3 fracture and T12L1 location, which we already know, were at increased risk of developing kyphosis. Most common fractures are type A3, and the most common location, L1 to D12. And this has been shown by not one study, but many studies again and again. And we all know this, that this is important, that posterior instrumentation is able to fix these problems, but you may have developed kyphosis afterwards. So how about if you insert a screw at the fracture site? Can you do that? So yeah, and there are now multiple studies suggesting that if you put in screw at the fracture level and then above and below, just one above and below, you're able to achieve better reduction and less loss of correction. So you have better results. So just by putting in 5 or 6 screws, you can have the same results that you have with putting in 8 screws, 2 above and 2 below. Similar studies, they compared the same thing and found exactly the same, that greater fracture reduction. And although they did not report long-term follow-up like Lee et al. So 2 by 2, just putting 2 above, 2 below, 4 above, 4 below, or 2 plus 2 along with fracture screw. There was no statistical differentiating between these patients that they had. Having said that, they felt that they were able to maintain extra stiffness and strength and have us better construct, but they were not able to differentiate that any of these had any difference according to these data. So if you had no difference, why would you put extra screws if you can do that 2 + 2 with a fracture screw? Um, so most of the studies eventually, according to this review, had that our knowledge founded on the retrospective data, majority of the time, with choice of treatment guided much more by each school's history and beliefs. So what I do is right, what everybody else does is probably not that right. So it's not on the basis of methodologically reliable comparative studies. The technical difficulty of procedure, its reputation as being aggressive if you'd want to do being anteriorly. So, and its potential morbidity logically limits its development, which is now facilitated by minimally invasive video assisted techniques. So some people are able to do that video assisted. Having said that, not that many people in trauma are using that because of further problems with. So if you can achieve the same thing by posterior approach, you can do that minimally invasive anteriorly if you have those facilities available. So in future, it may be possible that some people may be doing that. Having said that, from 2004 to up to now, there are very few studies with videoscopic or anterior, minimally invasive anterior approaches that are able to show the same results. Percutaneous pedicle screw fixation through the pedicle of fracture. Again, we just said that. Good therapeutic option in type A thoracolumbar fractures. And difference from traditional open surgery. So we know that that's going to be less blood loss, less pain, less surgical time, hospitalization period is reduced, and need for blood transfusion and post-op analgesia is much less. No difference between the techniques regarding the radiological results obtained. So open versus minimally invasive, putting in a screw through the fractured vertebra. So this study was discussed before as well, and I'll go through this. Thoracolumbar fractures associated with posterior ligamentous complex injury. These authors observed radiological improvement in both types of surgery, and now they were looking at both open versus percutaneous pedicle screws, including the fracture segment. They did not find any significant difference in ASIA score or degree of kyphosis with open versus this. And their statement, obviously, if you have less morbidity, less surgical time, less hemorrhage, blood transfusion is less. So maybe you should consider doing this for this particular type of fracture. And then there was a study by Wild who did not see any difference in the two groups. And there was no difference in surgical time, time of radiation exposure, and loss of fracture reduction. But they have been doing this for over time, so their radiation exposure with experience had reduced and was pretty reasonable. Grass. So what they did was percutaneous dorsal versus open instrumentation. This is again a study from ages ago, from 2006. And they said the same thing, that we are sparing the paravertebral muscles, avoiding muscular atrophy due to denervation and devascularization of the muscle, decreased blood loss, transfusion, infection, decreased postoperative pain. So same story. And they were able to say that although there is no unanimity, the fixation material used in percutaneous osteosynthesis is usually removed months after. So, but some people are doing that. Majority of the people are not doing that. So, but it doesn't matter what you do, the results eventually are the same. So the other way of doing this minimally invasive is to put in screws with monoaxial screws, percutaneous screws. And once you tighten them automatically, when you put in the rod and you tighten them, obviously it straightens up and then you can distract. And as Irfan was saying yesterday that, yes, when you have the screwdriver inside, if you don't take it out, it remains as monoaxial, even the polyaxial screw, and you can reduce the polyaxial screws just by this technique as well. So contribution of vertebroplasty, cementoplasty techniques in dorsolumbar hinge fractures. There have been multiple studies since 2005, and Europeans are way ahead of Americans on this, although many people have reservations because of the limitations of complications associated with this procedure. Percutaneous anterior spine reconstruction with some kind of polymethyl methacrylate or a bone substitute is increasingly applied in post-traumatic vertebral body fractures. So it used a Megrel type A, A2, and A3 fractures. So they said it could be used in isolation or associated with posterior reduction osteosynthesis. risk of intracranial body fragments mobilization, intracanal extravasal, obviously cement leakage, expected to progressively limit indications for anterior surgery. That's their overall consensus for. There is no consensus at the moment that if you do this, you are going to improve the outcome or the long-term results regarding deformity, progressive deformity in any of the techniques. So not many people are doing it. Having said that, there is no study saying that's not good at all. So indications for anterior surgery and neurological complications. So this study looking at anterior-only stabilization of three-column thoracolumbar injuries. And this is again from 15 years ago. Canal stenosis is mainly due to retraction of posterior vertebral wall, which is more efficiently corrected on direct anterior approach. So that was the consensus at that time. And even in 2005, I would be doing exactly the same thing what's written here. But slowly and gradually, we have evolved and able to do the same thing anteriorly in majority of the cases, although there are some guidelines regarding or recommendations that some particular fractures are better off probably doing anteriorly with the canal being compromised and neurological problems. So short segment pedicle screw instrumentation, augmentation vertebroplasty. And these are small studies that are saying they had reasonable results and they're able to improve kyphosis. But again, these are not prospective long studies. Majority of these studies are 30 to 40 cases. So really can't say much about these. And then, you could do lateral pediculectomy and circumferential reconstruction. And, all this could be done anterior and lateral approach both. And having said that, but there are significant morbidity associated, especially if you're talking about thoracolumbar trauma. So in elderly, pedicle osteosynthesis, three different type of population. They use solid screw, cannulated screw, and cannulated screw with MMA, PMMA. They had 5 cases of loosening. No mechanical failure was reported in cannulated screws with augmentation of PMMA. No rod breakage cases were reported. Again, the problem with this study is that number of cases are not that many. So although they reached a statistical significance, but this is a study with 50 cases each. So really, we don't know if we can really say that this is worthwhile. All stabilization methods showed good clinical results. Cannulated screws augmented with PMMA seem to provide better implant stability with lowest rate of loosening. So there is some evidence that it is possible. It may be slightly better, but this is not scientifically proven yet. Different approaches, not going to go into that. Percutaneous versus pedicle screw instrumentation treatment of thoracic lumbar spine. Again, percutaneous short segment instrumentation achieve good results with less complications. And then we talk about early versus late surgery for thoracic spine in multiple injured patients. So we're talking about polytrauma patient. So you're talking about if you have polytrauma patient, then this is a prospective study in level 1 trauma center, surgery within 72 hours or after 72 hours. And all of them were fixed posteriorly. Those who were operated early with hemoglobin on lower side showed poor clinical outcome. Careful selection of patient is required for those who have multiple injuries with thoracic spine fractures. And this was a level 2 study. Again, another study talking about early fixation for unstable axial fractures, retrospective data, level 1 trauma center, patient operated within 24 hours, after 24 hours. So this was pretty reasonable compared to the previous one, which was 72 hours. So those operated early had shorter ICU, hospital stay, and fewer complications than those who were operated after 24 hours of injury. And this was statistically significant. Pretty good data. The only problem is the retrospective data analysis. Biochemical parameters were not mentioned in the study, and different other problems associated were not included. So this was they were asking a simple question, that if you operate early or late, what's going to happen? So this is damage control surgery, basically meaning putting in MI screws, getting the patient up early, making sure they don't develop complications. And they showed that what we already know, that shorter ICU hospital stay may be there. So again, damage control, another study, prospective cohort study, fixed posteriorly within 24 hours or after. And length of ICU hospital stay, complication rate reduced in early surgery compared to those who were fixed in delayed fashion. So again, this showed that if you operate early in this and do a damage control surgery, that's possible that you can reduce all this and improve outcome and morbidity and mortality of these patients. So let me come to questions. Question 1. So in most cases, short segment posterior lateral pedicle screw fixation incorporating the fracture level should be sufficient for burst fractures. You want to vote on this or you want to change this? Mehmet? Yeah?
Is the literature completely support that the fracture level screw is necessary?
Yeah, there's level 2 evidence saying that in multiple studies.
We could have created another sentence
Sure.
Containing the fracture level screw add some support, something like that.
So we say that short segment posterior lateral pedicle screw fixation, and that's what we have said, incorporating the fracture level.
It's a combination then. Yeah. Do we think that only without fracture level screw we cannot make a
no. So what we are saying is that with these you can give better results with a fracture level screw. So that's what we're saying. So instead of putting 2 above, 2 below if it's junction, what you do is you put just 1 above and 1 below and into the fracture vertebra if you can, then the results are pretty good. If you can't, that's a different story. Obviously you go 2 above, 2 below. If you want to change the statement, let me know. We can change it. It's no problem.
I would rather tell, in most cases, short segment posterior screw fixation is sufficient for burst fractures.
If the pedicles are intact, sir.
Because
but then create another statement that a screw on the fracture side adds additional support.
Okay, so we can maybe say short segment posterior lateral pedicle screw fixation may be sufficient for burst fractures for, just 1 second, don't do that, for cases not involving the thoracolumbar junction.
Right.
So you can say that.
Right.
So we can specifically talk about if it's without thoracolumbar junction, it's okay. You can do that. But adding a fracture screw, obviously then you're getting more strength. So that's the whole idea of this statement. But if you want, we'll make a separate statement and have that. Okay, you want to say. So let's make 2 statements. So statement 1 will be, in most questions, short segment posterior lateral pedicle screw fixation is sufficient for burst fractures. And then statement 2. So let's vote on statement 1 and separate this. Let's just vote on statement 1. And then we say incorporating the fracture level is preferable for burst fractures at the junction. Yeah. But like, for example, if you've got an L3 fracture, thoracolumbar fractures include lumbar fractures as well.
But actually, thoracic and lumbar fractures we are talking. If we specifically say junctional fractures, then we must say something else.
So let's say that incorporating the fracture level at the junction, at thoracolumbar junction, is preferable for burst fractures at this level.
Yeah, it may be like this.
Incorporating the fracture level, incorporating the screw through the fracture level, or fracture level screw. Is preferable for burst fracture just delete this for burst fractures of thoracolumbar junction. Is that
Must
okay?
delete that should be sufficient.
It's preferable, but should be sufficient, should go. Good. And save that. Let's vote on 2.
Okay.
So this is going to become 3. Can change that. So this is the same statement going again in a different way. So we don't have to really vote on this if we have done that. Using long segment fusion, if fracture level cannot be incorporated in that thoracolumbar fracture. No. No. But we know that all the studies that have shown have specifically looked at T12 and L1.
But we must define here the type of fracture. Burst fractures we must have.
Yeah. So long segment fusion may be an option or can be used. Don't say necessary, because if somebody doesn't use it, they'll be sued in the court. So the idea of putting recommendations is that somebody cannot say, okay, look at these WFNS guidelines, and then you could be in trouble. Irfan Sab would be trying to explain. So long segment, just remove use and just say long segment fusion, capital L. Long segment fusion may be used at thoracolumbar, or we can say T12 L1 if you want to specify. Nicola, you want to say T12 L1? Okay.
Junction. We can say junction.
Okay. So that's fine. At thoracolumbar junction traumatic fracture, burst fracture. And then you have fracture. So just delete if and fracture. And maybe use the thoracolumbar burst fracture. If fracture level screw cannot be incorporated. Screw.
We can then say not maybe, should better be used. What do you think?
Is preferred, maybe the right word. Is preferred will save our surgeon sometime. So you have an option that it's the preference, but for whatever reason you can't do that, you don't have proper size screw or whatever. Or so I don't want to write.
Yeah, and even I could say you prefer to push you in the legal term in the court of law. If somebody says that I have done just a single short segment fixation, and if it's in the court of law, they will say that the preferred, the lawyer will go and press word preferred. So I think maybe probably the better word.
But then maybe will not be followed. With preferred, the whole idea is that as long as you can justify what you did, it's fine.
Yes, but I think you give a surgeon more authority to defend that. If you put a strong word, then the surgeon can't.
But preferred is not a strong word. Must is a strong word. Should is a strong word.
Absolutely strong word. Even preferred will also go in, but whatever the consensus.
Should better be.
Yeah, it should better be.
Should better be used.
Should better be is not an English sentence, so it's difficult. So it's better, you can say. Maybe better.
Better is the English word.
Maybe a better option, you can say. Maybe a better option. Maybe
is very weak.
Is a better option. So let's say is a better option. Preferably was much better sentence.
That is fine. That is fine.
I would change fusion with fixation.
Okay, agree.
Yeah.
Is a better option at thoracolumbar junction burst fracture if fracture level
Now it is good.
incorporated. So let's vote on this. 3. Okay, that's next.
And 4.
So all the literature says that for you, overall, fixation is necessary, fusion is not necessary. There's no evidence saying that fusion is necessary against our concept. Shall we vote on this? We can vote. Not so we just say but it's all thoracolumbar factors, so it's okay. Okay, next. So actually, the question is that we should read this. No difference between anterior and posterior fusion in terms of clinical outcome. We make this yellow and question. Maybe take it up there. Just no, just
After this.
And then say. So there is no difference in clinical outcome between anterior and posterior fusion. Just write down. Fractures actually. And this is for thoracolumbar burst fractures. There is no difference between anterior and posterior fusion in terms of clinical outcome. Anterior and posterior approach actually is the thing that they're looking at.
And you can delete the above.
Yeah, we will just delete that. There's no difference between anterior and posterior approach in terms of clinical outcome in thoracolumbar burst fractures. So we have removed that. So just remove this. Now remove that.
Yeah,
Question 5. Okay.
Okay.
6.
Okay. This actually was taken from this question was taken from the CNS guidelines. And does the surgical treatment of burst fracture of thoracic and lumbar spine improve clinical outcome compared to non-operative treatment? We have already voted on that. Nikolai, we voted on this before? Basically, it says there is not enough evidence suggesting anything. So we don't need to vote on this. Go next.
Remove it.
No, just go on the next. Okay, so this was another statement from them, but again, I don't think we have already done this. Go next. Does early surgical intervention improve outcome for patients with thoracic and lumbar fractures? So again, there is insufficient conflicted evidence because there are 2 studies saying there is worse, and there are about 5 studies saying that is good. So really, there is none. Do we need to vote on this? Less than 24 hours, damage control surgery. So basically, it is effective. It is, but the studies do not.
We have discussed that issue during cervical trauma, and we were for early decompassion. We can define here thoracolumbar trauma.
So if we read that it is suggested that early surgery should be considered as an option in patients with thoracolumbar fractures to reduce length of hospital stay and complication. The available literature has defined early from 8 hours to less than 7. So this is the statement that we can give. The second statement, can you delete the first? This one. And make this question. Is this question 6 we are voting on? 7.
We skipped the 6th one.
So this becomes 6.
Okay. 6.
So this, bring it here. Yeah. This recommendation statement is actually not question statement. statement. Is that okay, or you want to change the sentence?
Yeah, let's revise it. Early surgical intervention for thoracolumbar trauma, and we can, in parentheses, write it early for first 24 hours.
In bracket, you're saying?
Yeah.
Okay. So
Can improve outcomes.
early surgery, and so bracket, less than 24 hours.
When you're talking about outcome, it's not so clear.
No, it's this. We are talking about length of stay, complications. That is outcome. So then delete this second sentence.
This one.
Yeah, and yeah. Delete that, and move this down. Grade B. So this becomes statement. Let's delete this. Just question 6 remove, and make this big. इसको बड़ा कर दो, बोल्ड कर। नहीं वो नीचे वाला नहीं। क्या कर रहे हैं? Okay, so we are voting just on the statement. Six. Okay, go next. We've talked about choice of surgical approach. Actually, there is no difference, whatever you do, depending on, so go on to next. So does the addition of arthrodesis instrument infection improve the outcome in patients? So we have already voted on this, saying fixation. So this is, we have already voted on before, so we don't need to have this. So let's go the last. Does minimally invasive technique, percutaneous instrumentation, affect outcome in patient undergoing surgery for thoracic and lumbar fracture compared to conventional open technique? So there is evidence. No, we're going to go, we'll make this question 7, and it won't be there, don't worry. It won't be there. Just go there and you go back and just delete 7 here so that we don't have 7 here. Okay, come to the next. 7. So stabilization using both open and percutaneous spherical screw may be considered in the treatment of thoracolumbar burst fractures, as the evidence suggests equivalent clinical outcomes. Can we vote on this? So the question statement is not going to be 7, statement is going to be what we have in the white.
This is the same statement of CNS guidelines?
We have changed a bit, yeah, but yeah, the wordings were kind of same.
Instead of that, we can just tell that minimally invasive techniques, there is no evidence that minimally invasive technique influence the outcomes. Is there an evidence?
The evidence is that less complication, less hospital stay, less pain. So that is outcome as well. So we can just say that minimally invasive techniques may be considered in treatment of thoracolumbar burst fractures, as the evidence suggests equivalent clinical outcomes compared to open surgery. So we have a safe statement.
Yeah.
So just say that minimally invasive techniques, delete stabilization all the way down to screws, delete may be considered in thoracolumbar burst fractures as the evidence suggests equivalent clinical outcome compared to open surgery. Is that okay?
Yeah, this is better.
That's 7. And we are done. Go next. And we are doing the skull-based course in May, as we were talking about. So guys who are sitting in the back, all are welcome. This is endoscopy versus skull-based. We have 6 faculty who are going to be talking about endoscopy and 6 of open skull-based surgery or microscopic skull-based surgery. So, and there'll be dual about many cases in this. So you're welcome.